Hello, my name is Harman Chavla. I am a pediatric intensivist at Presbyterian Hospital. The next lecture series that we're going to go on to is Pediatric Acute Respiratory Distress Syndrome. And in particular, we're going to discuss the epidemiology and the definition behind the syndrome today. The summary of the recommendations that we have for you today are derived from two major sources. One of them is the Pediatric Acute Lung Injury Consensus Conference, or PALIC, and the other one is PARDI, the Pediatric Acute Respiratory Distress Syndrome Incidence and Epidemiology. So with this, we'll dive right on into the epidemiology. Take a look at the pediatric ARDS numbers that we have. As I'm sure many of you already know, respiratory failure is the most common cause of death for children, especially those admitted to the pediatric ICU. ARDS actually accounts for up to 10% of pediatric ICU admissions. And when we start looking at them by individual numbers, pediatric ARDS has a pooled mortality of about 24%. But overall, this has been a trend that has been decreasing, especially over the past 3 decades, with better recognition of the disease and better management strategies that are being standardized across the board. The best prognostication really for how a patient's going to do with ARDS comes from a 6-hour stratification of severity level. These are all numbers that we'll dive into later on in the presentation. So now when we start looking at the definition, really was put forth by PALIC, and there are criteria that you have to meet before you simply get to the hypoxemia. For example, there is an age requirement that patients that have perinatal related lung disease are not included within this patient population. In addition, the timing of the hypoxemia has to be within 7 days of a known clinical insult. The clinical insult itself can vary a fair amount, anything from transfusions to trauma to infection and sepsis. In addition, the origin of the edema has to be basically respiratory failure, not explained by cardiac failure or fluid overload. And previously, there were restrictions on what really constituted ARDS imaging. Now, essentially, the patient just needs to have a new infiltrate consistent with acute pulmonary parenchymal disease. Once those criteria are met, then the degree of hypoxemia needs to be delineated. And to do this, there's a bit of a breakdown in terms of if you're on a non-invasive form of support versus an invasive form of support. So if you are in a non-invasive form of support, this basically means that you are on bilevel ventilation or CPAP. And at this point, you wind up having to calculate either a PF ratio or an SF ratio. The calculation for those are listed right here. Of note, the PaO2 does need to be derived from an arterial blood gas sample. If you are an invasive form of mechanical ventilation and you can take into account the degree of pressure that you're providing for the patients, then there's two major formulas to use. We will go over the oxygenation index, where you take the mean airway pressure, multiply it by the fraction of inspired oxygen. If you're calculating this and you're actually doing the full percentage, then you do not need to multiply by 100, but if you're using a fraction or a decimal, then so based off those calculations for hypoxemia, these patients can be stratified into mild ARDS depending on their OI or OSI, moderate ARDS, or severe ARDS. It's also important to note that we can identify patients that are at risk for developing pediatric ARDS. These are patients that are supported still on nasal mask CPAP or BiPAP, oxygen via mask, nasal cannula, or high flow, but they don't quite meet the requirements as listed previously with regards to the degree of hypoxemia. And also, if you are on mechanical ventilation and have a saturation equal to or greater than 88%, but with an OI less than 4 or an OSI less than 5, these are patients that can be considered at risk for developing ARDS. Now, why does this stratification matter? Well, if you actually look at the numbers, and these numbers were derived from the PARDI study, PICU mortality itself changes a fair degree once you start transitioning out of the realm of mild to moderate ARDS into severe ARDS, almost seeing a tripling of the numbers. The 90-day mortality follows a very similar trend, and the number of days that you get ventilator free from both invasive mechanical ventilation and non-invasive mechanical ventilation is statistically different depending on the degree of severity you have of your ARDS. So patient stratification does matter. In addition, from a management standpoint, when you take a look at patients that have mild ARDS, as delineated by this blue line here, you can see that 3 days out you have an approximate intubation rate of about 35%, whereas if you start going into the severe category, these patients have a much higher likelihood of being intubated. As you get 3 days out, only about 40%, slightly higher than 40% of these patients actually remain on non-invasive ventilation. Really big conclusions to draw from this talk is that pediatric ARDS is very prevalent in the pediatric ICU, and there is a great deal of importance that's based on the definition of the disease and the disease syndrome, primarily so we know what we're treating, and afterwards stratification of that disease as well, so that we actually know what risk category the patients fall into. Thank you.